We now, since we are doing all of our classes virtual, the entire college, we got an emergency notice that Northern Virginia Community College has used up all of their memory for Canvas. So we've had to also go in and clean up our recordings and delete them and that type of thing. So it's been a wild ride this weekend. I hope everybody had a nice weekend, and if you celebrate Easter, I hope you had a wonderful Easter. We are going to be going over chapter 29, which is the orthodontic patient today, and not 31, so 29, and then we're also doing nicotine disorders. So that's the patient who smokes. So we'll be taking a break in between. We're going to get out early today. Yay! Always a good thing. Ortho, we are not an ortho. Hygienists usually don't work in an ortho office, but we have had students that have gone in after they've graduated that were an ortho assistant and then turned into the treatment coordinator and the one who took all the impressions and the treatment plan presenter to the patient instead of the doctor. Who here, can I have a show of hands, has worked in an ortho office? It's very different than private practice. So next navigate is 29 and 32. You are correct, Amanda. So ortho always looked ortho always looked more difficult to me because there were multiple patients in the chair and having to fit the brackets and the bands and all that other stuff. Now, ortho is changing dramatically with the Invisalign and all the other companies that are coming out. So it's not what it used to be, where you're going to 3D imaging and computers are doing everything for the dentist now. And you can even do that over the counter and do it mail order. So the philosophy of how teeth move hasn't changed. And that's what you need to know about more than the different techniques, because there are a number of different techniques out there. But you will be faced with patients on a daily basis that either have ortho brackets and bands or buttons on their teeth, depending on the system that they're using. So your boards don't have a lot of questions on ortho. Mainly it's about gingival overgrowth that can occur with the moving of teeth, as well as oral hygiene and bone loss, versus the ortho system itself. But you do need to know the different types. When I was in braces, they didn't have bonded brackets. That was before composites were really in. So I had the typical metal mouth where there was a band around each and every tooth. And that was really metal mouth. So who can tell me some of the advantages of the bonded brackets? Anybody got their book open? And I've got crickets out there. Aesthetics. Thank you, Karen. Aesthetics is one of them. Yes, especially if you are a teen or preteen or an adult. Aesthetics are always in consideration. The another advantage is also the cleanability of things, because you only have a little bit of bracket bond on the facial surface of the tooth instead of having the surface area of a band all the way around the tooth, a metal band all the way around the tooth that's cemented on, and then the cement can leach out, and then you've got not only a plaque trap, biofilm trap, but you have the potential of decalcification and decay. So there are more advantages to the bonded brackets than disadvantages. Think about surface area. Think about those bugs in the mouth. They like to collect around anything that's difficult to clean. And when you have ortho, everything is more of a challenge. So we've got the brackets. Usually the brackets are on all the teeth except for, say, the sixes, your first molars, possibly your second molars as well. They'll put a band around. You have an arch wire, which is telling the teeth where they want to go. Okay, as far as putting pressure over here to help the osteoclasts dissolve the bone, because you're trying to move the teeth where you want them to be with pressure. And that's the arch wire's job. Then you have your elastomers, your little, the elastics that go around that help put everything together. There are removable aligner systems out there now. So the patient, if it's, I'm just using Invisalign as an example, you use the Invisalign system. So they give you, the office, everything you need. You have to use their impression material. You have to use all of their own products. And you take the initial impressions and then you send the impressions off to the company. They use a 3D scanner and they plan out in advance all of your aligners. And they're like little clear retainers that fit over the teeth. And those retainers or those aligners are the ones that put gentle pressure on them. So it's important that the patient wear them as directed. And the nice thing about wearing aligners is you're not eating and drinking a lot during the time that you're wearing them. You take them out during meals. So hopefully they're not drinking Gatorade and high sugared things, because the solution is going to get in the aligner, between the aligner and the tooth, and then you've got this recipe, so to speak, for disaster. They are also using 3D images now instead of taking impressions to get the mouth. This is where it is, and then computerized imaging takes care of the rest. So we've really come a long way with these removable aligners. Has anybody gone through the aligner system? So Pam, how did you find it? Was it easy to use, easier than you thought?
I had a lot. It was fine until my canine randomly died, and I had to get a root canal.
Both or all four? I mean, just the maxillary ones?
Just my 11.
Oh my gosh. And it just randomly, they couldn't figure out what happened.
Correct. Yes.
Oh, I'm so sorry. Yeah. That is a randomly died.
Yeah. Yeah.
Oh my.
Other than that, it was fine, but
Well, are you blaming, or are you associating the aligner system in any way to number 11?
so I had I went to like 2 oral surgeons and a periodontist and an endodontist, and they took some of the 3D the CBT, and the root was totally tipped out of the bone, like completely.
Oh.
Yeah.
Oh.
Yeah.
And that, my friends, is the advantage of having a 3D CBCT scanner. Because an orthodontists are using them more and more, especially as their pan machines need to get replaced, because it does tell you the thickness of the bone.
Yeah, so the pan looked totally normal, obviously, but then when they did that, it was not good.
Not good. So what did they do? You've got a root canal on number 11, and then what else?
I have a root canal on 11 and they finished the treatment. It still bothers me to this day, like 5 years later, it doesn't feel right. But it was never infected or anything, and there's nothing wrong radiographically.
It just moved out of the bone. Okay.
Yeah.
Did you need any tissue grafts or anything around the area, or bone grafts?
They did not do that, no.
Okay. Huh.
Yeah.
I'm sorry. Yeah, when Invisalign first came out, that was the only brand out there, and now they've got competitions, but it was only for tweaking. They only did minor movement of things, and it wasn't for the typical orthodontic case. Then you had to go to traditional ortho. So now, with the longevity of these systems, they're doing more and more complicated cases. And I'm not really that familiar with the Invisalign. Um, so to speak, you have to use a slow movement no matter what system you use. The teeth have to move slowly. So Lita's saying, even with braces, number 10 died, and oh my gosh, and has root resorption. Root resorption is one of the disadvantages of any ortho system that you can use that you have to be careful of. Slow movement, and those roots never come back. So we've got a small class. We've got 27 students, and guess what? Two have had complications out of the ones that have had Invisalign. That's not great statistics if you were doing a evidence-based study on this. Those numbers would be too small, but oh my goodness. So you're using the system to take however you take the impressions with the system, and then you send things off. The computer does everything for you, and then the patient will typically get either all of their aligners at once. They'll get a box of them, or you go into the orthodontist office once a month, and every 2 weeks you're changing your aligner. However, the ortho office is set up. Now, this is one of the problems with the over-the-counter, the ones that you can get through the mail, is they don't have these 3D scanners, etc., to prevent the possibility of number 10 or number 11 moving out of the bone, and then you've got a disaster on your hands. And this can happen with traditional ortho as well. So there's buttons placed on teeth. They put a little bit of bracket bond that they call a button, just a little glob of it, to help the aligner kind of hold on. And that helps aid the gentle pressure of the teeth. But the aligners are typically about every 2 weeks. The clinical procedures for bonding, now this is if you're going to be doing bracket bond for brackets as well as buttons. You want to have an assessment. There are procedural steps that are related to more dental assisting, where you don't want fluoride on the tooth surface. You're going to acid etch the tooth to open up those pores, and then you place the bonding material on. It's usually a light cured bonding material, and that hardens it, and then you're good to go. So bonding is easier than debonding, because bonding, you're just adding the material to the tooth, and hopefully the doctor is using a fluoride releasing bonding system. So fluoride is leached out, especially around the margins of that bonding. But you, as a dental assistant, I have never needed to do this. I've never worked in an ortho office, have to debond the brackets. But I can tell you, I have been a hygienist for so many years. There have been times where I've spent a half an hour just trying to get that excess bonding material off. So we have complicating factors, right? These aren't necessarily guaranteed failures, but we have to take into consideration as the hygienist, the age group that we're working with. Are they going to be motivated to take care of their teeth the way they're supposed to? And there are certain age groups that are more motivated than not. So we need compliance, patient compliance. And we also need to know if it's mature bone or immature bone. Immature bone is going to move much faster than mature bone. What is the periodontal health of the patient? If they have gingivitis to begin with, and then you're putting all of this stuff in their mouth and on their teeth, their gingivitis is going to be worse because they're already prone to infection and they're not starting out healthy. If they have bone loss as well because of periodontal disease and that apical migration of that junctional epithelium, their teeth are going to move much quicker. And are you going to be doing more damage than good? The positioning of the teeth, are they rotated? Are they just facial verted or lingual verted? How much movement does that particular tooth need to go? A little bit of movement is always better than a whole lot of movement, right? It's just more predictable. And then there are problems with appliances. They are uncomfortable. They make your teeth hurt. Sometimes they make your whole mouth hurt. You are mouth breathing. You can't eat with them, and they poke you. So they can be a problem. And then cleanability is also very difficult for the patient. They've got all these plaque retentive surfaces, especially if things are cemented or bonded in. Think about that arch expander. They've got metal and a gate almost on their hard palate. How is the patient going to clean that? And especially if you are an 11-year-old that doesn't care in the first place. So we are responsible when the patient comes in to reinforce self-care instructions. And we're talking oral self-care. That's the term that's being used more now than oral hygiene or home care. We're trying to get away from the term home care. And just like biofilm versus plaque and tartar versus calculus, we're trying to elevate the language to be more descriptive of what we're really talking about. So it's oral self-care. It emphasizes that this is your job as the patient. Toothbrush selection is important, as well as having them have the floss threaders available or the super floss if that's what your office is recommending, or the Proxa brushes. I'm a big fan of using the Proxa brushes with ortho. And toothbrush selection, as well as toothbrushing technique. Who remembers the name of the toothbrushing technique that gets on top of the brackets? Bass is the gold standard. Bass gets underneath the gum tissue, so you still want them to use the Bass, which is 45-degree angle towards the gingiva to work those bristles subgingivally. But then the Charters is the opposite of that, where they're angling the toothbrush towards the incisal or occlusal surface, and that gets the top of the bracket. So they have these special ortho brushes, which are designed to have that center portion of the bristles cupped out, and you can get on top and underneath of the bracket. But guess what it's not doing? When you're using an ortho brush, you still have to angle the brush to get the bristles underneath and on top. So just holding the ortho brush like that is not getting everything that it needs to get. So you need to be able to get on top of the bracket as well as underneath the bracket. And then you need to get underneath the gum tissue. So the patient's really needing to do 3 separate steps with the manual brush. That's a lot of commitment. So we're doing the bass, we're doing the charters, and we're doing something called the bass, a modified bass, to get underneath the bracket. So we've got our bracket here and then the gum line here. So we need to get the bristles underneath the gum. We need to get them on top of the bracket, and we need to get them underneath the bracket. And then we've got our wire going from tooth to tooth. So that's where I like my Christmas tree Proxa brush, because it gets right under here and it gets right under here, and you can clean this portion of the bracket, the mesial and distal portion of the bracket. Then the toothbrush will clean the top and bottom of it. Who has had ortho already in their chair? Patients with ortho. Okay, Amanda, tell me about it. What did you have to do?
It was horrible. It was my daughter, so I was also extra sensitive about how much she was bleeding, but the amount of gingival overgrowth, I was shocked by. Like, you almost could not get on top of her bracket at all. The gingival overgrowth went all the way to the top of her bracket. So when we were probing and cleaning, she was bleeding like a lot. So that was very sad. But flossing was not easy either.
And it takes some dedication to have somebody, especially a teen or preteen, floss with the floss threader in between each and every tooth.
Yeah.
They're in that bathroom for a long, long time. Yeah. Karen, how did you do with your ortho patient?
My ortho patient was Amanda's daughter.
Oh, okay. So, and Amanda, did you realize there was gingival overgrowth prior to her being in the chair?
You know, I had looked in her mouth to try to kind of prepare her for what was going to happen, but no, I had not realized there was like no space above her brackets. And I guess that's not abnormal. I don't know. I panicked when I went in there with a probe.
And what were you probing?
Like, what was her probing depths?
Yeah.
She had a lot of 3s and some 4s. I don't think she had any 5s, but then again, I was trying not to go very deep because she was bleeding so much.
Okay, now we're going to rephrase that. I was trying not to go very deep. You need to go as deep as you need to go to get an accurate reading. You wanted to apply light pressure so you weren't injuring the tissue, correct?
Yeah, and when we did have our assessment, we were on target with the depths that we got, but it wasn't, so she had overgrowth in every one of her, everything except for her 4 anteriors. There was overgrowth, except for her 4 anteriors and her second molars. Everything else had overgrowth on it. And so there was a lot of 3s, even though it wasn't really 3, because you have to add.
Yeah. And gingival overgrowth is not uncommon. Just the act of having the brackets on there and putting pressure on the teeth can create that gingival inflammation and gingival overgrowth. So it's not necessarily related to their oral hygiene. The act of moving the teeth can create a gingival overgrowth situation, not necessarily a reaction to their oral hygiene, or not correlated with it. Now, having said that, the better the oral hygiene and the stimulation to the gingiva, the less gingival overgrowth you'll generally see. If that mouth is going to gingival overgrowth, it's going to gingival overgrowth. Just like the calcium channel blockers and some of the other medications your patient might be on. Meticulous oral hygiene is essential. So, and we'll get into that in a little bit. But dental hygiene instrumentation is weird also, because you have to go when you've got your brackets. Okay, we've got our gum tissue here, and then you've got your brackets you can probe an instrument underneath the wire around here, but then you can't. You've got your bracket extending out. So this area here is going to be over angulated. Okay, you're not going to be able to stay nice and straight, parallel to the long axis of the tooth with that. So you have to take some of these things into consideration when you're probing as well as when you're scaling. Somebody who's got a fixed retainer on the bottom teeth, mandibular anterior teeth, it's not uncommon. They finally get that retainer off. You're going to see a lot of calculus underneath that arch wire. You can't clean like you normally do as a dental hygienist. But look at all the maneuvering that that patient has to go through. So you've got the lingual is easy because you've got your Bass technique for the lingual. And how do I know that's the Bass and not the Stillman's?
The angle, the
Well,
45 degree.
the angle is going to be the same, okay? It's still 45-degree angle. But with the Bass, you've got most of the bristles trying to get underneath the gum tissue here and very few on top of the gum, versus the Stillman's has most of the bristles on top of the gum. So these two tufts would definitely be on top of the gum. So anyway, that's just a little bit of, they are two different brushing techniques. So this is more of a Stillman because you have to be able to, you can't get the brush quite as close to the tooth surface. But you want to get underneath the gum tissue. That's critical. You want to get on top of the bracket as well as underneath the bracket. So you can see even with an ortho brush, you have to do all of that maneuvering. What I find for patients is that the patient usually does better with their biofilm removal if they do one technique at a time. Go through and do the entire gum line area. So I have them do this one. I'll have them do this one first. Do all of that. Then they'll do this one second. Go all the way around. And then they'll do this one third. Tooth, 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 instead of having to have that wrist go all the way around. Alexis was talking about no rolling. Well, we don't know if the rolling is in, and the rolling is, okay, is when you're rolling it, and that is the modified Bass or modified Stillman. And again, this is my personal preference. I don't like the modified because you're wiggling, wiggle, 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 wiggle for a count of 10 and one roll, and then you go on. Wiggle, 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 wiggle for a count of 10, one roll, and go on. I don't think one roll is especially effective if you have thick biofilm. So you've got the patient with ortho. You will be seeing that patient in private practice, and you are going to be, yes, hopefully disclosing them. I disclose every child coming in, even if they're 20 minutes late and they've been eating Oreos or Cheetos on the way to the office. I send them to the bathroom. I have them brush their teeth because that's not my job, and then I will disclose them. All right, which means by the time I'm done with them, I'm 40 minutes behind schedule, but that's okay. That's my job. I also have ortho patients, children and adult, oftentimes coming in more frequently. Maybe every 6 months isn't adequate. I had one child coming into me every 4 weeks to 6 weeks. He refused to brush. He was at TJ. Yeah, he was at, this brilliant kid. He just had no social skills, and his self-care was horrendous. So I had him coming in. Adults are very motivated to want to keep things clean. And if you need them every 3 months or 4 months or whatever the routine is, they will oftentimes come in because they are making the investment in themselves. But debonding is usually done at the ortho office. You're done. Let's get all of this bracket bond off your teeth. We're taking the brackets off, and then we're taking the bracket bond off. And this is when I really disliked seeing the bonded brackets, because I would have the patient come back with either resin all over their teeth, or the dentist was in a hurry and went through the enamel, and then they just have maintenance issues after that. So we want to avoid any enamel damage. All right, so loss of enamel is one of them, and iatrogenic are things that we cause to the patient. The bracket bond came off, they take a high-speed burr, and try and smooth off the bracket bond. They go too deep, and I have seen patients come back to the office that they've needed a composite placed there. But there is an increased enamel roughness that can occur if the orthodontist doesn't take the time to go through the various burrs and discs to smooth out the enamel, just as you are as a dental hygienist. If you use a coarse prophy paste, you have to use something finer to buff out those scratches, because if you're using a coarse prophy paste, you are scratching that enamel and you're removing root surface. So you want to buff things. So our goal is smooth. Smooth bacteria doesn't cling to quite as easily. So some orthodontists are better than this than others. So you want to, the goal of debonding is to remove the resin bulk and to minimize the damage to the pulpal tissues. So you don't want to be doing a lot of jiggling of the teeth and torquing. You want to leave that enamel surface smooth with enamel on it. And that's the hard part. Especially using a high-speed handpiece, how you don't want to remove enamel, because guess what? It never comes back. The main thing that you need to know about debonding, and I've seen this on your boards, is to not twist. Let's see if I've got a picture here. When you're they have like a little clamp, the jaws of life that go on, and you don't want to twist. All right, that twist means that you are torquing, and you can create damage to the pulp. You can also create damage to the tooth. So you just want to snap it off. Do not twist. Then the dentist, this is what takes a long time. This is some of the stain around the bracket bond here. And you can see the little hashtags for the where the bracket bond was. And the dentist needs to take care to try and smooth this off without damaging the enamel. I've seen disasters coming in. If you are a hygienist and end up seeing this, I would send them back to the orthodontist. It's not your job to remove it. And I can't tell you how many hours and hours I have spent trying to remove this type of stuff. You need a handpiece for it. But occasionally there'll be a little spot here, a little spot here, and the patient, when you're scaling, you're looking for it. You can sometimes see it when you disclose, but you can see it and you can pop that off with your scaler very easily if it's just a little piece like that. And the patient will go, oh yeah, because you'll ask them to put their tongue on it. Can you feel the difference? Yes. Then you ask, are there any other areas that need to be worked on? Because you are the perfect person to get this and that off of there if it's just one or two spots. because you're taking your time and you can't clean their teeth if you are busy trying to get this bracket bond off. But their tongue enlarges and magnifies so they can tell you where it's rough. And if there's just too much of it, you send them back to the orthodontist. So this is not tooth structure that's being removed. This is bracket bond, but you can see that they have a huge cutting. It's very coarse there. So take a look at that versus this is a nice smooth. So that's the biggest issue with trying to smooth things out. And this is something that the dentist does. Hygienists are not allowed to use a high-speed handpiece. Dental assistants aren't allowed to use a high-speed handpiece. Then they've got these special discs that will help polish. They have some coarseness impregnated into them, and you go from the coarse to the finest, trying to get a smooth, glossy surface without scarring. Post debonding evaluation. That's what you are probably going to be seeing, excuse me, because they'll take the braces off in the ortho office and then they say, go get your teeth cleaned. And they send you back to the hygienist. So you want to look for this enamel loss. This is where fluoride preparations during the time of ortho is important. So the patients, ortho patients I had, usually I would put them on an amorphous calcium phosphate paste, the MI paste, ACP, right, to buffer the enamel or buffer the saliva as well as encourage fluoride absorption from the water and the toothpaste and other things. And then I'd also have them use a prescription strength fluoride gel, usually a 5,000 neutral sodium fluoride that doesn't stain, to help keep everything as mineralized as possible. So orthodontists are key for taking pictures, pre-ortho pictures. And part of that is so you can see the before and after, but another part of it is for risk management on their part, so they can document where there are white spot lesions and other discolorations of the tooth before the brackets were even placed. And then you take the brackets off and the before and after. Well, Johnny had this before we placed them. So the dentist needs to really be careful when they are etching the enamel to place the bracket bond, okay, that they're not over etching, but we need to be sure that we are getting our fluoride varnish there when the patient comes in, as well as that they are receiving adequate oral health care for their individual needs. Retention phase is also key. If you don't wear your retainers, you're going to get collapsed. These teeth have memories. The periodontal ligaments have memory. They want to go back to where they were. And if they're not in a fixed place yet, that retention phase, you're going to end up with collapse and failure of the ortho. So a retainer needs to be worn. They're now recommending that the retainers are worn for a longer period. It used to be, well, until you had your wisdom teeth extracted, then you could stop wearing them. Well, we have patients that have been in the retention phase for years and years because it's the only way you're really going to guarantee that things aren't moving. But retainers, whether they are removable or fixed, are also another source of biofilm retention. So we really need to have the patient bring in their retainers, even if they're not wearing them during the day. Let's bring them in. We'll clean them in our ultrasonic. We'll brush them up. Calculus can form on those just as they do on regular teeth. post-bonding preventive care. That's something that you are going to be doing. Perio evaluation. Immediately after ortho, it's not the best time to take your probe readings because things are still inflamed. But you want post-care radiographs. And the dentist or orthodontist usually will be taking pans to see where those root surfaces are in conjunction with where the crown of the tooth is, or is that long axis of the tooth where it's supposed to be. So pans will tell you that more than bite wings and periapicals. But periodontal evaluation, things are still settling in. So an immediate post periodontal evaluation is still tentative. You do what you can, but then you also want to check them later. Dental examination, you're looking for caries on areas that you haven't been able to examine before, and fluoride therapy is essential. So we are documenting ADPIDE. That last D is for documentation. We are evaluating that patient every time they come in, and we're monitoring their compliance. There have been usually kids that have needed to have their braces removed because of non-compliance. So if they're not going to take care of things, then, or if they're having an adverse reaction because of other things, maybe they're on other medications that's just creating that gingival overgrowth in an exaggerated form. Sometimes they need to have their ortho removed. Are we going to learn how to clean those retainers? The retainers, you mean in the clinic, you're going to clean them just like you would clean a denture. You take your baggie, you put it in the baggie, you take the put the baggie in a cup, you take it to the sterilization area, you put the solution in, and we've got all sorts of solutions from Effordent, you know, the over-the-counter cleaner, to tartar and stain remover liquid, to the powder that you put warm water in. You put that into, mix that up, put that in a beaker, fill the beaker with water, put the beaker in the ultrasonic, and you turn the ultrasonic on. And then if you have denture brushes in your office, typically you'll use a clean denture brush and give the patient the denture brush to use at home. So that's what we do when we're in the office. Okay, we're looking at it to see how clean it is and praising the patient if it looks really clean, just like their night guard and other removable appliances. Now at home, they need to do the same thing. They need to take a toothbrush to their retainer if it's a removable retainer. So they can put the Effordent in there, it bubbles while they are brushing their teeth, and then they take the toothbrush, can be their regular toothbrush, to brush with that, and they brush that off for the friction, rinse it really well, and then they can place it in their mouth. You can use anything that you want for your skill evaluation on care of prosthesis. You have one that you have to do before you graduate. So everybody's going to be making a whitening tray in dental materials this summer. So if you don't have anybody coming in with an appliance, it's fine. You can use your own whitening tray. That's fine. You just need to do one before you graduate. All right, and we walk you through where everything is. Your goal is to spend most of your time reinforcing oral self-care for your patients and making sure that they have things that they need. All right, recommending certain products. I'm a big Proxibrush person. I love using the Proxibrush underneath the brackets for ortho. I even get the Proxibrush out and I will put my Prophy paste on that Proxibrush and use that to brush underneath the arch wire. I will use their manual toothbrush. We've already done OHE, but I will get their manual toothbrush that I've used for my instruction, and I will place some prophy paste on that and try and work around the brackets that way. If you have a prophy jet, that air powder polisher, it's wonderful for getting around brackets. And you don't even need to floss with that one because it blasts around and in between the teeth. But I can tell you, this is just tooting my own horn here, I will take the time and floss my ortho patients. Well, many hygienists don't because it's a pain in the neck and it takes time. But if you don't floss and show them how important it is, but you tell them to floss, it's not reinforcing at all. What other adjunctive needs does the patient need to use? Is it amorphous calcium phosphate, the ACP preparation? Are there fluoride rinses or pastes or gels that you're recommending? How frequently do they need to come in? Is every 6 months adequate for them, or do they need to come in more frequently? So the big thing with ortho is OHE. The big thing with ortho is